the absence of signs, in the absence of signs or symptoms attributable to urinary tract infection. So even if you got a bunch of white cells in your urine, if you have no symptoms and you have bacteria in your urine, that's called asymptomatic bacteriuria, just like it says. This is extremely common. So in young, healthy women or in premenopausal women, pregnant women, only 1 to 5% of urine has bacteria in it with no symptoms. But older folks in long-term care facilities, especially women, 25 to 50%, patients with spinal cord injuries who get straight catheterizations or long-term catheter use, it is more common to find bacteria in the urine than not. And in the absence of symptoms, that's not harmful to the patient and it does not benefit from treatment. We know this. There's a lot of data that treating asymptomatic bacteriuria, so if there's no symptoms but there's bacteria in the urine, that's not beneficial. Treatment of asymptomatic bacteria does not and is not associated with any long-term adverse outcomes. For example, hypertension, which could be, from kidney damage, that doesn't seem to happen. Chronic kidney disease, genitourinary cancers, or mortality. There seems to be no benefit of treatment. And it does not decrease the frequency of symptomatic infections in the future. So if you find bacteria in the urine and you treat it with no symptoms, it doesn't mean that you're going to prevent somebody getting sick a week or a month later. It does not prevent recurrent bacteriuria. So over and over, this can come back whether you treat it or not. In fact, there's signals that treatment increases the risk of antimicrobial side effects, of course. You can't have an antibiotic side effect if you're not on antibiotics, but also increases the risk of reinfection with organisms that are resistant to antibiotics in the future. In patients with catheters, treating bacteria in the urine when they don't have symptoms does not decrease the risk of a fever in the future, but it does increase the risk of resistant bacteria in the urine in the future. So we do not recommend treating asymptomatic bacteria almost all the time. So do not treat asymptomatic patients. It's hard to improve upon asymptomaticity. If you have an asymptomatic patient, it's unlikely antibiotics are going to make them feel better. So in non-pregnant women, in diabetics, old people, institutionalized people, spinal cord injuries, patients that are not getting urological surgery, maybe somebody's getting heart surgery or a hip surgery, or a patient has a catheter, they do not need to be screened for bacteria in the urine, and they should not be treated even if you find bacteria in the urine. But there are a couple exceptions that are important. Pregnant women, we do recommend screening in early pregnancy. There is a higher risk of preterm labor and of pyelonephritis if patients have bacteria in their urine early in pregnancy, because the ureters do tend to get impinged later in pregnancy, and they are at higher risk of pyelonephritis in that situation. So we recommend treatment 4 to 7 days. Nobody knows for sure if patients should be rescreened later in pregnancy or if antibiotics should be continued after an initial course, and the practice and management of that varies. The second thing is, prior to a transurethral resection of the prostate, we recommend 1 or 2 doses of antibiotics just 30 to 60 minutes prior to the procedure, usually just a single dose right prior to the procedure. Or if somebody's getting a urological procedure where there's going to be bleeding mucosa, this is usually like a stent placement. If there's bacteria in the urine and you result in bleeding of the urothelial mucosa, then infection is more likely. So these are the instances where there's evidence-based to treat asymptomatic bacteriuria. Other cases, there is not. Why is it so prevalent to overtreat asymptomatic bacteriuria? 20 to 80% is inappropriately treated. And so years ago, a survey was done of resident physicians in training who should be up to date on this stuff because they're being taught right in the same time period and they're managing these patients every day. And this survey showed that 32% of patients were inappropriately treated, and they were given 7 vignettes. So only 37% were totally correctly answered properly. And most of the reasons they said were they were worried that the patient might have a postoperative infection, or they were worried about inflammatory markers like maybe a white blood cell count or CRP, or they were worried because there were white blood cells in the urine, even when the patient had no symptoms. So here are some of the questions. We don't need to go through all of these, But even the first one, a 50-year-old man with hypertension just had a physical annual exam and had no symptoms, but somebody sent a urine and cultured the urine. There were white cells in the urine and there was E. coli in the urine. The patient was asymptomatic. So he should not be treated, and the diagnosis is asymptomatic bacteriuria, and only 32% of the patients got that correct. The other concern would be the converse. Number 5, a pregnant woman, 12 weeks gestation, no urine symptoms. She presented with pyuria, had white blood cells in the urine, and the urine grew E. coli. So she has asymptomatic bacteriuria, but because she's pregnant, she should be treated. And only 30% got that one correct. And half of them didn't even get the correct diagnosis. So now this has evolved. This is from 2015. And I think we've really been preaching about UTIs, especially asymptomatic bacteriuria, for 10 years now. I think we've gotten a little bit better, but I still see almost every day in the hospital this being mismanaged, unfortunately. Okay, I need to move this banner. Let me see here. Oh, there we go. So do not screen for or treat asymptomatic bacteria before surgeries. Okay, so we have, what is going on with this? Here we go. Okay, so there is no benefit to screening for bacteriuria prior to cardiac surgery or spine surgery. Also, asymptomatic bacteriuria is not associated with post-operative joint replacement infections. So here's a paper from 11 years ago. And when I first started practicing here 15 years ago, patients were getting urine cultures prior to either heart or joint surgeries. And then I was called on occasion saying, should we cancel the hip surgery because the patient has bacteria in their urine? And of course, they also have bacteria in their mouths. There's no way to sterilize a mouth. And my tongue-in-cheek response on occasion was, you know, why are you putting urine in the operative field? Or why is urine getting in the surgical site? And of course, it's not. So in this study, they looked at patients that had bacteria in the urine, asymptomatic before hip surgery or joint surgery. And they found that although those patients did sometimes develop joint infections, the bacteria that caused their joint infections did not match the bacteria that was in their urine before the joint replacement. So even though patients that have bacteriuria might be at some increased risk of having overall infections, maybe because they're less healthy people, the bacteria in the urine is not associated with what happens with their hip. Okay. So how about altered mental status? Frequently we hear, well, patient's old and they're confused, but they have no fevers, nothing else going on. They probably just have a UTI. I was certainly taught this 25 years ago. But the thing is that in long-term care residents, like in nursing homes, cognitive impairment is very, very common. And so is bacteriuria. 50% or more of women who are elderly have bacteria in the urine at any given time. And there's no evidence that asymptomatic bacteriuria alone causes delirium. None. No evidence that treatment of asymptomatic bacteria resolves delirium. Many patients that are thought to have a UTI come in the hospital, get a urine checked and have bacteria, but have no fever, no evidence of infection, rapidly improve when they're just given a little bit of fluid for dehydration, or they're given a little bit of medicines to calm down their agitation. So urinalysis is not actually indicated in a non-catheterized patient just to work up mental status change. So what do we do for patients in long-term care residents who have this issue? So there is a criteria. There are two different criteria. The Loeb criteria I've referenced here. And they basically say that if a patient has acute dysuria, so seems to be having pain or discomfort with urination, or has a fever plus frequency, urgency, suprapubic pain, hematuria, CVA angle tenderness, or urinary incontinence, those two things, that should prompt workup. But simply altered mentation does not require urine cultures and in fact discourage. And those Loeb criteria will be listed in the reference section. Okay, so let's talk about cystitis. So this is infection of the bladder. Cystitis, inflammation of the bladder. It's very common in healthy women. There is no fever and no flank pain. There really should not be fever with cystitis. I suppose some forms of severe cystitis could cause fever, but as a general rule, there isn't fever. So in non-pregnant women who have a first-time UTI, who come in with some burning dysuria, maybe a little bit of blood in the urine, and they're well, and they haven't been receiving antibiotics in the past, they can be treated with a first-line drug that has over 90% activity, and a culture is not mandatory. In fact, it's not really recommended. So either nitrofurantoin or cephalexin are highly active in our antibiograms and are recommended there. However, we avoid Bactrim, trimethoprim sulfa, because most sites in Alaska have over 20% resistance. And fluoroquinolones also, most recently we have at Providence about 82% susceptibility of E. coli, but also they're very broad. They cause more Clostridium difficile diarrhea, joint toxicity, and there's even a black box warning basically saying don't use these drugs if other options are available for non-severe infections. Also, I should mention, in the hospital, when somebody has a quote-unquote UTI, if it's not asymptomatic bacteria, which is what I usually see, then oftentimes somebody ends up with a urine test done when they're already hospitalized and then is placed on ceftriaxone or an IV antibiotic because there's white blood cells in the urine. And most of those patients have no symptoms or perhaps have cystitis, in which case they don't even need an IV antibiotic. They could just receive an oral antibiotic. And we'll talk more about resistant organisms later. Okay, pyelonephritis. So this is infection of the kidney, and fever and flank pain are kind of the hallmark findings. It's rare to have somebody with pyelonephritis and have no symptoms. These patients also oftentimes have abdominal pain, nausea, or vomiting. It's very important to get a urine culture before giving antibiotics. There's always a big rush to give antibiotics immediately. It's really important to get a urine culture first, otherwise you won't know what you're treating. So, and patients with a fever who are sick and vomiting can be a little dehydrated, so giving them some fluid so you can try to get a urine is important. If they can't urinate, a catheterization could be done. But if antibiotics are given, it can be very hard to make a correct diagnosis. So what we recommend is a beta-lactam. If somebody is sick and vomiting in the ED or being admitted, typically IV. If there's no IV, an IM shot of ceftriaxone is appropriate, although it's kind of painful. And then cephalexin 1 gram TID for 7 days is a standard recommendation at this time for patients that are ambulatory. Option 2 would be an oral fluoroquinolone, but this would be best to be avoided if the E. coli susceptibility is less than 90%, and it is in many of our facilities. There may be slight outperformed treatment success compared to a sulfa medication. So it would be Cipro or levofloxacin for 5 to 7 days, depending on the dosing. If you use a higher dosing of 750, 5 days is adequate. We put together a Alaska UTI guideline back in 2018 that pretty much mimics what I just showed you. Now let's talk about patients that are a little sicker, patients that have a kidney infection and have bacteria in the blood. So in fact, we don't uniformly recommend blood cultures in ambulatory patients. If somebody's in clinic or urgent care and has fever, flank pain, but can tolerate orals, a blood culture is not required. Sometimes they get done in people that are in the ED because they don't know for sure they're going to be able to be discharged or not. It's understandable, but they're not required. If a patient does have E. coli in the blood, for example, in a kidney infection, and they're getting better on appropriate treatment, it's actually not necessary for them to come back to the hospital, be admitted, or anything like that. It's good to call and check on them, make sure they're getting better, of course. You should do that anyway. But this is not an emergency if the patient's on the correct treatments and getting better. However, if they're not getting better, if it's been 48 hours, 72 hours, they're not getting better, then you'd be some concerned perhaps there could be an obstructed stone or some complicated situation, and imaging would be reasonable. It does take people with kidney infections a few days for the fevers to go away. They usually gradually feel better day by day, but fevers can linger for a few days, but they should be getting better. If they're not getting better, there could be a problem. So we used to think, and I remember in meetings not that long ago, 7, 8 years ago, even antibiotic stewardship meetings, where there was still a clinging to the concept that a fluoroquinolone like ciprofloxacin, levofloxacin, or even maybe Bactrim, a sulfa medicine, ancient medication, that somehow that was better than an oral beta-lactam drug like cephalexin. However, in our pathways here in Alaska for 13, 14 years, we've been advocating higher doses of oral beta-lactams for discharge or for outpatient treatment. And now the new data clearly supports that a shorter 7-day duration and that oral beta-lactams are non-inferior to other options. So I'm going to talk about that here briefly. So when patients have gram-negative bacteria in their blood or potentially other organisms, there is extensive recent data that shorter regimens, like 7 days, are typically adequate. Just the other day, I was asked by somebody who was taught that if there were bacteria in the blood, the patient should get 2 weeks of antibiotics. And that does seem like old teaching that is not supported by evidence-based medicine. So there are two important studies, well, there are multiple actually important studies. I'm just going to mention two here. One of them is a balance trial in New England Journal of Medicine from last year, 3,600 patients. These patients were bacteremic, mostly from urine sources, although this study actually included other things like biliary infections or other infections that were not Staph aureus. So this could be pneumococcus group A strep. And these patients were sick. They were ICU patients as well as just floor patients. And they looked at 7 versus 14 days of randomized treatment, and they found similar outcomes in both. I'm going to show you that in a minute. Another important study was from the VA of 4,000 adults, and they retrospectively looked at patients that were given IV beta-lactams or switched to oral beta-lactams for gram-negative treatments, and they found no difference in mortality or relapses in those patients. So the first is the balance trial. It's getting a lot of attention, as it should. 74 hospitals in 7 countries, and there were ICU patients, but Staph aureus was excluded. So Staph aureus is its own beast. And this plot shows that patients treated in the study had strong evidence that 7 days of therapy was non-inferior to more than 7 days of therapy. So non-inferior with non-overlapping confidence intervals. So there was strong statistical significance in this finding. The VA study is here in JAMA Network Open Access, so you can get this without any protected rights. And they found equivalent relapse and mortality with step down to oral beta-lactam. So 30-day mortality, 90-day mortality, repeat hospitalizations, no statistically significant differences. They used a lot of different regimens here. They used amoxicillin when it was active, amoxicillin clavulanate. We tend to use more cephalexin. It may not actually matter that much, the beta-lactam selected and the dose of the beta-lactam. We think a high dose of cephalexin is very effective and well tolerated, and there is specific literature to support the 1 gram TID dosing in some studies as well. Now, patients with complicated urinary tract infections, this is if I get a call from somebody, another doctor saying, hey, I have a patient with a complicated urinary tract infection, I just want to know exactly what they're referring to, because it's an old, messy historical term that can apply to a lot of different things that are not always treated the same or have the same risk. So technically, in the old guidelines, this is cystitis or pyelonephritis. So you could have just plain old cystitis, but accompanied with an abnormality of the urinary tract. So this could be stones or strictures, could be BPH, so you don't empty your bladder, could be something congenital. Any hardware or instrumentation like catheters, stents, recent procedures, any of that would be included in complicated UTI. Poor voiding, like we mentioned with a BPH, or maybe neurogenic bladder from spinal cord injury, with a bad neurogenic bladder, reflux, and transplant. So some people say transplant could be a complicated UTI. It's because infections are thought to be harder to eradicate in these patients. And, if imaging shows that there's hydronephrosis, so the kidney's swollen up with urine because it's blocked, and the patient has infection, fever, flank pain, and the kidney is blocked and not draining, That's a really urgent problem that patients need to be seen in the hospital, and a stent or a percutaneous tube really needs to be placed in the kidney quite urgently to decompress that infection out of there. One thing that's important to recognize too, just mechanistically, if you think about it, let's say your right kidney is swollen up with urine because the ureter is completely blocked with a stone, and you come in with a fever and really bad right flank pain and vomiting, but a urine is checked from your bladder and the urine is normal. That can occasionally happen because that infected kidney isn't communicating its urine down to the bladder. So the infection's all up above the stone, and the urine in the bladder can look normal. So there are instances where a urine can be normal and you could have a bad infection. It just mechanistically makes sense. To have a high suspicion for pyelonephritis with flank pain, fever, vomiting, abdominal pain, and the urine's okay, imaging is important. Of all of these things, indwelling catheters, Foley catheters, or suprapubic catheters are by far the most common cause of, quote unquote, complicated UTI. So we need to talk about catheter UTIs briefly. There was a guideline specifically addressing these in 2009. It's still quite old, 16 years. But this requires, so again, any infection, the word infection signifies disease or injury or harm to the patient, so there has to be symptoms. So you have to have, at least in the old guidelines, it was 10 to the third. So the actual quantity of organisms isn't so clear, but there has to be one or more organisms from the catheter, specimen, or midstream void, or a midstream void less than 48 hours after a catheter removed. So if you take a catheter out of somebody, the next day they have symptoms, it's still sort of called a CAUTI. Fever, shaking chills, malaise and lethargy, and you have no other cause, or you have flank pain, hematuria, etc. So if somebody's sick or ill appearing and they have a catheter in place, that's a concern. So remember the lobe criteria I mentioned about nursing home patients previously was applying to non-catheterized patients. If there are no symptoms, it's asymptomatic bacteriuria. So just last week I got a call, or maybe Monday or yesterday, patients came into the emergency room with bladder pain. Her catheter had been pulled out the day before and she hadn't been able to urinate. As soon as they put a catheter in, she felt better because her bladder was decompressed, and she was fine without fevers or anything else, and no more pain once the catheter was in. But the urine was sent to the lab and there was white blood cells, and she'd had bacteria in her urine 6 months or a year prior, and they wanted to know what antibiotic to give her. And from what I could hear, she was asymptomatic at the time they were calling me. She had pain because her bladder was the size of a basketball and they drained it. So I said, that's asymptomatic bacteriuria and I wouldn't treat that. Smelly or cloudy urine is not a symptom. That's not pain, dysuria, etc. It's kind of gross. Maybe the patient had some asparagus the night before or something, but it's not a symptom of infection. It certainly may mean that there's bacteria in the urine, but that would just go along with asymptomatic bacteria. And also, white blood cells in the urine is not a symptom. Many patients have white blood cells in the urine and doesn't bother them, and that does not need to be treated. So we should not screen for asymptomatic bacteria prior to or after catheter placement, which is kind of what happened on this patient the other day. Okay, how about culturing catheterized patients? So if a patient has a catheter in long term and they need a culture, so at a rate of somewhere between 3 to 8% a day, catheters become colonized with bacteria. So after 30 days, there's 75 to 100% chance those catheters are going to grow some bacteria if a culture is sent from the catheter system. So first of all, you can't get a catheter-associated urinary tract infection if you don't have a catheter, like by definition. So generally, we want to get catheters out for people that don't need them. Regular straight cathing is an option for many patients. So when in doubt, generally we need to get it out. Sometimes patients just had surgery on their urinary tract and they can't come out, but when you can get it out, you want to get it out. If there's a catheter in place for more than 7 days, most facilities recommend replacing it and sending cultures from a new catheter before starting the antibiotics so that you get an accurate result. This is somewhat controversial. I'll show you one paper on that briefly. Yeast. Yeast is commonly seen in the urine in patients with catheters or in patients with asymptomatic bacteriuria. In very large cohorts of yeast in the urine, 97% of the time it's not treated. And in those large cohorts, there were no complications in untreated patients. So we do not recommend treating yeast in the urine in virtually all circumstances. If there's blocked hardware or a stone completely blocking a kidney that actually has yeast up in the kidney, that's a bigger problem. It's quite rare. Those patients are sick, and an expert needs to help with those, urologist or an infectious disease expert. We usually recommend changing the catheters in patients with bacteriuria from the catheter that has symptoms, if they have symptoms, or if there's yeast there and they have symptoms, but we don't recommend treating yeast. So this study was just last year, I think. 52 patients that they looked at with catheters, and they basically did the obvious thing, which is just check a urine before taking the catheter out, and then 2 hours after a new catheter was put in. So these were mostly hospitalized patients, for example, that got a catheter put in when they were admitted, and then a few weeks later, they wanted to check a urine for some reason. And they did find that it made a difference. So patients had a 36% chance of having a positive culture if it was taken from the port, and only 28% if it was taken from the new catheter. And the organisms did not match in many cases. So cultures with different results from specimens before placement, 32%. So a third of the time, the bacteria were different. So it does seem important probably to change catheters. Nobody knows exactly if the threshold should be 72 hours, 7 days, 14 days with the catheter in place before changing it. But changing the catheter before sending cultures probably reduces the inappropriate diagnosis. And that's nice to have some data to support that, because we haven't had that until recently. How about preventing catheter-associated UTIs and asymptomatic bacteriuria? Minimize catheters. Used to be every patient who was making urine had a catheter in the hospital. So we need guidelines for who needs them. We need to have the orders immediately let nurses take them out when they're no longer indicated. And then try to keep the thing closed. We recommend not flushing junk up into the bladder when there's debris in the tube, or when the tube gets kinked off. That's not good. You want to make sure the tube runs downhill. You don't want urine backing up into the bladder. And then the perineum should be cleaned frequently to try to minimize bacteria crawling up in there. Okay, so if there's a catheter urinary tract infection, you really need the cultures to know what to treat, because patients generally tend to have a mixture of bacteria, or bacteria that is more resistant to antibiotics than a young, healthy woman in her 20s that has mild cystitis. So most of these catheter-associated urinary tract infections don't have fevers in our experience. They just have some bladder tenderness or discomfort. So there's really no reason that you can't use macrobid or cephalexin orally when able. That's really what we prefer. Macrobid should not be used if there's renal failure. It's not effectively getting into the urinary space in that situation, and should not be used if there's fever. But if it's just cystitis, cystitis drugs are okay. We typically treat for 7 days. 5 days is a levofloxacin. If you need to use that drug for some reason, is also an option, but we try not to use it if there's other alternatives. There is a caveat that younger women under 65 who just have cystitis, if the catheter is removed, you can give 3 days of treatment. So let's talk a little bit about over-treatment of urinary tract, of suspected urinary tract infections, for example, like out of the emergency department. This was a pharmacy resident paper from last year, but there are many of these now, and many emergency departments are putting together callback programs where those cultures, if somebody's got a possible UTI, a urine culture sent, and then they're sent out of the emergency department with a prescription for Keflex, for example, that those cultures should be followed up. Historically, what's happened is only the positive cultures then come back to somebody's inbox and they review it and call the patient if they're on the wrong antibiotic. but there has rarely been a process for calling patients back that have negative cultures. Because if somebody maybe had cystitis, they have white blood cells, they got antibiotics, but they don't have a urinary tract infection, they shouldn't take 7 days of antibiotics for something they don't have. So these programs are putting into place callbacks with negative testing. This one lumped together treatment for chlamydia primarily, but sexually transmitted infections, so either urinary tract or STIs, and the ED pharmacist would call these patients back. And they found out they could eliminate 80% of the antibiotics that were given in their ED for people with quote unquote cystitis or UTI that had negative urine cultures. Through the pre and post intervention days, dramatic decrease in patients that needed to take all those antibiotics. And they did not have any complications in this intervention group. It was a small study, but I like this one from the pharmacy residents, so I want to give kudos to them. But there are many others that show the same thing. Okay, so what about resistant organisms like E. coli with resistance and UTIs? About 5% in Alaska based on our antibiogram last year. There's not a lot of great treatments for these. If somebody's ill, particularly, we've oftentimes been stuck with ertapenem once a day. If there's just cystitis and they don't have renal dysfunction, nitrofurantoin frequently is still active against these isolates. Then the other treatment that can be very helpful in tricky situations where a patient could go home but doesn't have oral options is single dose aminoglycoside, which I'll show you in a minute. In a tiny subset of patients who have an MIC less than or equal to 8 for amoxicillin clavulanate, that can be used 500 for 5 to 7 days, twice a day, but only if it's cystitis and the MIC is less than or equal to 8. For years, we've been thinking you might be able to give a third-gen cephalosporin and amoxiclav, but the data is just not evolved enough to allow us to do that. Finally, we occasionally use fosfomycin, which is actually a 3-gram saturated powder that has a broad activity against gram-negatives. And a single dose has a long urinary excretion, so we can get away with this. It's very active historically against ESBL E. coli, less so against Klebsiella. The problem is we can't get susceptibilities back in any kind of non-geological time. So sometimes we reach to this as an option out of clinic or something, but we don't do it real commonly. The other problem is that the microbiological cure is poorer. Clinical efficacy is still about 90%, but it's just not a real potent treatment. But we do use this for cystitis sometimes in patients that are known to have an ESBL E. coli, 3 grams once. Now, here's the single dose aminoglycoside data. This is actually just from a year or two ago also, and it's nice to see this data evolving. So the question is, what if you give a one-time aminoglycoside dose for ESBL UTI, including Pseudomonas, if it's a Pseudomonas that's resistant to oral therapy, and the patients have cystitis? So this study looked at patients that got a single dose of aminoglycoside, 5 per kilo, gent or tobramycin. If you use amikacin, it's 15 per kilo, just a single dose. And they had similar relapse rates, readmission rates, and safety profile as patients that were given standard of care, which was like 7 to 10 days of a carbapenem. But the hospital lengths of stay
Mine is not charging any batteries. If you just want to pop this one in there.
I hear somebody talking. I don't. Who's talking? Am I hearing somebody?
Yep, someone needs to mute. I'm trying to figure out who it is.
Okay, thanks. So the lengths of stays were 4 days in the group that got aminoglycosides versus 14 days in the other group. So probably they were diagnosed with a UTI, found to have resistance, given an aminoglycoside and sent home. So I'm doing this more and more in calls from the ED or in the hospital. They don't need to stay for 7 to 10 days or anything crazy. Just give them aminoglycoside times 1. Okay. All right, so we've been about 37, 38 minutes. That's our CE slide. And I think what I'll do is just, let me stop sharing. Okay, so I've got my other screen up. Yeah, so let's move on if there's any questions. I'll figure out how to get my chat back.
If you have questions, you can just unmute and ask or pop it in the chat, whatever you prefer.
This is a very bread and butter topic, so I figured there may be some controversy. I tried to cover as much as I could. It's good to know everybody's got this all sorted out and has no questions. Any advice for me would be useful because I see problems every day with this topic.
So I'm coming from a pharmacist perspective. So how do you get providers to, I guess, kind of respond to, I guess, when you're trying to tell them like, hey, yes, I see this patient has, some bacteria in their urine, but they are saying, I don't have any pain, I don't have any of this, and yet they still want to treat them. Like, what is the appropriate response?
It's easier for me because I'm the ID doctor and I'm the
Right,
stewardship
right.
person. I can just tell them not to do it, or I can consult and stop it myself or something. If they won't respond to you because they don't respect you or think that you know what you're talking about, then you should send them the literature.
Okay.
Because you can say, hey, I'm sure you believe in evidence-based medicine. This is really an exciting time for our field. And here's all the literature that treating asymptomatic bacteria does not reduce hypertension or future fever or future renal disease or anything, but does increase the risk of resistant organism in the future. And there's very, very clear guidelines on this.
Okay.
I think it's because of what I showed you with the students answering these
Right.
questions. It's just anal sphincter tone. And but if you always do something and you don't not do it, then you don't know not doing it's okay. And if you want your hand held and you work at a hospital where there's people that are available to hold hands, like our hospitals, then we can help with that. It's definitely harder if you're at a small place and you don't have experts that those doctors trust to help them. But
Right.
you got to keep whittling away at them with data and with logic.
Okay.
Yeah. So don't give up.
Okay. And then I guess for like the long-term care side of things, what about the patients? So the patients that are, I guess, that already have dementia and that are having those episodes, and so they just, retreating them over and over for a UTI. How do you kind of break that?
Well, I mean, that's a great point to point out. Hey, you're treating them over and over for UTI. So it doesn't seem like treating them over and over for UTI is accomplishing much because they keep getting UTIs.
But,
and
they're going to come back
cognitive
and be like,
impairment.
they seem better every time, right? So,
Well, cognitive impairment waxes and wanes. And typically
right.
it's not only an antibiotic that's given and nothing different. There's usually either additional medicines given or fluid hydration or something's changed. Electrolytes can be out of whack, all kinds of stuff. So if it's a skilled nursing facility, that's easy because that's exactly what the lobe criteria is for. I mean, this is a standard
Okay.
skilled nursing facility quality metric. I mean, these
Okay.
are well accepted guidance in that setting. It's a little
Okay.
harder for old people that are in an inpatient hospital and like an
Yeah.
acute care hospital for a month or two. That's not exactly the same population.
Okay.
But that's where
The low
prospective audit
criteria.
and feedback from the stewardship program is supposed to try to help also.
Okay. Well, I was looking to see
It's
what they
hard.
actually are using. Thank you.
Yep. And then if I can't avoid it, if you can't get somebody to change their mind, then you got to at least say, hey, instead of giving cefamega kill-all, can we give nitrofurantoin or something? I mean, you got to pick your battles and at least like, hey, if somebody's asymptomatic and you refuse to stop the antibiotics, can we use something that isn't going to hurt the patient? So that's another attempt, option.
Okay. Thank you.
So how do you handle a patient with a dirty UA but may not be able to answer questions about symptoms due to underlying schizophrenia? Oh, yeah. Yeah, if they think they have a member of Congress coming out of their bladder or something, that is hard to work through. I guess I would try to push on the bladder and see if it hurts, and then I would try to bang on the back, see if it hurts. And if the patient's had a urine test because they stubbed their toe and they have pyuria, but they're there because they're having a schizophrenic episode, I guess I wouldn't worry too much. If they're schizophrenic and they're there with a temperature of 104 and they're vomiting and the white blood count's 25 and the urine's abnormal and they can't tell you anything, then I would, assume that there's pyelonephritis and treat it. So that depends. That's a the physicians need to make that determination based on their assessment of the patient. I would hope that they wouldn't send a urinalysis with reflex culture on a schizophrenic patient because they're schizophrenic, but rather it's a schizophrenic patient here with a fever and a high white blood cell count or something, right? So you want to send the right test when you have a differential diagnosis first, rather than what we sometimes see is everybody that's already in the waiting room has labs ordered before they've even been interviewed and had a differential diagnosis constructed by the provider. So getting back to basics can help a little bit with that, but these are challenges everywhere for sure. Okay, there's a question about crafty techniques for driving provider buy-in on support of a nurse-initiated protocol for catheter removal. So you need to have a like a CAUTI work group or an infection prevention work group with a physician champion. So then you get a physician, hopefully, that's been at the facility for a while and is going to be there, that has some personal relationships with the doctors on that work group. And then when there's a agreed upon pathway for nurse-driven catheter removal, then that physician champion tells the doctors about it, lets them know, and goes to meetings. And if there's pushback about this protocol, then the work group can let the physician champion know, and the physician champion can talk to the providers. So providers are not going to respond to being told what to do by somebody that doesn't have a medical license and doesn't have the ultimate responsibility for the patient's well-being. They've got to be partnered with somebody who's also a provider, who has similar responsibility and fiduciary interest to make sure they're doing the best things for the patients. It's really critical. So you got to have physician champions for that stuff. Okay. Any other questions? Hopefully that answered people's questions.
There's one more in the chat. It's from Madeline.
The ESBL.
Yeah, ESBL.
Yeah. Oh, gentamicins just once, 5 per kilo once. So for, complicated UTI. Well, so for catheter infection or something like that, one-time dose is fine. If somebody's septic, with a stone obstructing their kidney that hasn't been stented, then a single dose of gentamicin would not be a good idea. This is why complicated UTI term is a real problem, because I don't know exactly what you mean by complicated UTI. If they just have a catheter infection, you change the catheter, give them a dose, and send them home, that's fine. If they're sick with a blocked up kidney that hasn't been fixed, then that would not be fine. So it depends on the scenario. Okay. Good. Getting more questions. This is excellent. What are your thoughts on the guidelines up for public comment right now for complicated UTIs? I haven't looked at them recently, Katie. So do you have a second to give anybody an update on any major changes that are being proposed?
Yeah, so I can show my face too, I guess. They are talking about when to use each drug by your antibiogram instead of giving like a general recommendation. But one of the weird things they're doing is they're saying you can use Bactrim even if it's less than 90% as an empiric option, and you just recognize that it's not going to work in a lot of your patients. And I think they went down to 80% is what they said. So if you're missing 2 in 10 patients, they're okay with that. So they had some like kind of off the wall recommendations, but the like base of it was going back to using your antibiogram and picking things that work for your region. But they were trying to clarify the complicated, uncomplicated a little bit better. So nobody really likes exactly what they said, but they're like happy that they're moving towards using your antibiogram versus general recommendations.
Yeah, it does seem counterintuitive to give Bactrim to somebody with a CAUTI that you don't have cultures yet. It's not likely to be real effective. However, a lot of people with mild CAUTIs, mild cystitis from catheters will get better without antibiotics at all. So I think that it's not real critical in that situation. I don't think anybody would ever do that, somebody who's septic. So, like, again, complicated UTI, an obstructed stone, or an obstructed stent and they're septic, you're not going to give them Bactrim in the hospital. That would not be good. So I think I don't have a big problem with it, other than I don't understand why it's necessary, because you could also just use cephalexin and then say you're going to miss 10 to 20% of infections, but then it's a lower, I mean, Bactrim's way more morbid drug to give than Keflex. There's way more chance of renal dysfunction, rashes, all that kind of stuff. So hyperkalemia, all these older patients with diabetes to get hyperkalemic on Bactrim, there's really not a reason to do that. So, but we know in many systems that we worked in that there are people that cling to sulfamethoxazole like I don't know, Lex Luthor and kryptonite or something. So anyway, eventually it'll go away. All right, elder with dementia, increased confusion, inability to tell you if they're in pain, groaning, grimacing during toileting, poor urine output, increase in wandering, increase in agitation, no fever, and positive dipstick. How would you proceed? Well, first of all, I would congratulate you for ever getting reliable urine out of that patient. I assume that was a straight cath or something, but holy cow, that sounds like a patient you'd have to put in shackles to even get a urine sample. So kudos for getting the urine sample. It also reminds me I never want to work in a nursing home for the rest of my life. So thank you for reinforcing that I'm happy what I do for a living. I think if somebody is appearing to be in pain and groaning and grimacing during toileting, you'd have to assume that maybe there's some type of discomfort with toileting, including maybe urinating, and that if the urine's abnormal and there's a problem and they seem to be having suprapubic pain or dysuria, you would treat them. So, you know, but it's a hard one to be 100% certain about. I'm also not a big fan of dipsticks. I don't think dipsticks should really ever be done. Urine should be sent with microscopics to quantitate the red cells and white blood cells and to look for bacteria. These rapid urine dipsticks are poor tests. So urine with microscopics definitely a better test. Got time for a few others if there are any. Can't solve all these urine problems, unfortunately. Sometimes it's unknowable. It kind of be some provider do less or do more kind of person. You want to make sure how sick the patient is, and just sometimes you just have to go with what seems to make sense.
I'll drop the CEU information back in if anyone needs it.
Great. Okay. Well, in 2 weeks will be our next talk, and the topic is I think it's abdominal stuff.
Yep, March 19th at noon, intra-abdominal infections.
Okay.
We'll see you all then.
All right. Thanks, everybody. Take care. Bye.